Why can some people have 20 liters of fluid and, yeah, they're short of breath, but they generally can tolerate it, and the dialysis patients get into trouble so fast? And the answer is that steep part of the diastolic fluid curve. The last thing we want to see is people's blood pressures 170s, 180s all night, because that person has a high risk of going into flash pulmonary edema. And that's kind of a terrible outcome that's preventable, makes the nephrology team feel bad, and everyone feel bad because the patient came in saying, "Hey, I should get my dialysis." And we've said, "Oh, you wait until tomorrow," and they flash and get intubated or BiPAP. Terrible outcome. And that can be partly mitigated by blood pressure control.
That was Dr. John Danziger, a nephrologist at Beth Israel Deaconess Medical Center. Welcome to the CoreIM 5 Pearls podcast, bringing you high-yield, evidence-based pearls. I'm Dr. Sheree Trivedi, and I'm joined by...
Hi, I'm Dr. Nathan Kudlapur, internal medicine resident at Beth Israel Deaconess Medical Center. Today, we're continuing themes from the last episode, digging specifically into nuances of blood pressure management in end-stage kidney disease, aka ESKD, patients on hemodialysis.
Yes, I love this episode. I got so much out of thinking deeply about blood pressure and, in all honesty, wish I had this teaching so many years ago.
I know, such an important topic, so let's delve into it. We'll start by running through the pearls.
As always, test yourself after each of the following pearls. Remember, the more you test yourself, the deeper your learning gains.
Pearl 1, blood pressure targets.
What numbers are we typically aiming for in patients on dialysis?
Pearl 2, timing medications and dialyzability.
Before a dialysis session, do you give blood pressure meds or not? And how does a medication's dialyzability affect when you give it?
And Pearl 3, pharmacologic management nuances in dialysis patients.
Which blood pressure medications have good outcome data in patients with dialysis and which ones don't? I think we've all been there, imagining our patients waiting in a long line in the pharmacy, not really sure what their medications might cost or if it's in stock. Amazon Pharmacy was actually built to remove barriers for patients. On the clinician side, I love that you can see how much their medications are going to cost right away. And then on top of that, Amazon Pharmacy goes ahead and automatically applies any manufacturer coupons or things, for example, from GoodRx. In your EHR, you simply have to search Amazon Pharmacy nationwide home delivery, just like you'd search for any local pharmacy. Send that prescription electronically. Your patient then receives a text message that walks them through the easy, quick setup. And so patients get their meds delivered fast, often same day, and they have access to a pharmacist 24/7 if they have any questions. You can learn more at pharmacy.amazon.com/prescribers and see if it's a good option the next time you have to ask, hey, do you want your meds to go to the local pharmacy or do you want it delivered at the convenience of your own home? Here at CoreIM, we're talking about the real things that can help anyone who works in healthcare. And today we're talking about how the scrubs you wear, they can make a difference. I remember the first time I saw one of my colleagues walking into a sign-out room looking way more put together after a night shift, and I knew right then and there they were wearing FIGS. FIGS Scrubs is made specifically for us, doctors, residents, students, healthcare professionals who are putting in long hours and really need gear that can keep up and perform on our level. We have so much going on in any shift, right? Scrubs are the last thing we want to be thinking about. And that's why FIGS is great in that they're lightweight, stretchy, breathable. They have all the small touches that have made me a true convert. They're clean, they're modern, super functional, tons of pockets that I love for all the snacks, zippers that don't snag, and antimicrobial fabric to stay healthy while working. You deserve better scrubs. You deserve FIGS. So head over to figs.com and enter FIGSRX at the checkout for 15% off your first purchase. That's figs.com, promo code FIGSRX for 15% off your first purchase. And with that, let's head back to the episode. Okay, so in our last Five Pearls episode, we really hammered home to me that it's really volume that is the primary driver of blood pressure in dialysis patients, among other things. But our first move should be to challenge that dry weight before adding blood pressure medications. And also to say out loud, one of the biggest things we can do sometimes, as we heard in some of our stories from patients, is sodium intake, right? Every gram of salt in a dialysis patient is fluid that they can't excrete until the next session. So volume management and salt restriction are the way to go.
But the reality is, we're often meeting these patients at different points in the hospital or clinic, and their blood pressures are all over the place. Nurses will be paging us about a blood pressure of 170 over 90.
Yes, exactly. What do you do with that page? And you're like, do I act? Do I not act? And maybe the first thing to do is start with what is the blood pressure we're actually targeting in patients who are on dialysis?
Okay, so even a step back from the numbers, there are two big categories of blood pressure readings to know about. The first is peridialytic blood pressure. These are the readings obtained right before, during, and right after dialysis in the dialysis unit. And then there's intradialytic blood pressure, everything in between sessions.
What we know from a lot of really good data is that it's the intradialytic blood pressures. So the blood pressure between dialysis sessions that has the strongest association between, blood pressure readings and cardiovascular mortality, all-cause mortality as well. And so those are the numbers for, a nephrologist, for an internist. If they're trying to manage someone's hypertension, those are the numbers that we should be using and not so much the blood pressures that we see in the dialysis unit.
That's Dr. Erica Drury, a nephrologist at University of Rochester. So it sounds like it's the intradialytic blood pressures, the blood pressures between dialysis sessions, that are more strongly associated with outcomes. So I guess what is our target then when we see this patient in on the floors, in clinic, in between dialysis sessions? What are we aiming for?
So, unfortunately, there's no consensus on specific blood pressure targets in dialysis patients. Some nephrologists use observational trial data in the dialysis population, and some extrapolate from the general population data. So, get ready for nuance.
Womp womp. I was hoping it'd be an
Mhm.
easy answer.
In general, we extrapolate from guidelines for the general population. So a target blood pressure of less than 130 over 80 is reasonable for most dialysis patients. And how should we obtain those blood pressures? So the gold standard, as in the general population, is ambulatory blood pressure monitoring.
Okay, so less than 130 over 80. That sounds very familiar, but I'm sensing a big but coming.
There is. And it's a big one. Because when you actually look at the outcome data in dialysis patients, there's a different range of blood pressure that's associated with the best outcomes.
If you look at the relationship, the association of blood pressure to mortality, what the curve looks like, it's really interesting dialysis. So generally for, the general population, worsened blood pressure, worsened outcomes, we're aggressive with blood pressure control. That is not true in dialysis. So if you look, the data suggests that the lowest risk of the best outcomes are for those whose blood pressures are in the 140 to 150 range. And that gives you about a 1 year mortality of about 12%. If you go up to a blood pressure of about 170, right, real hypertension, the mortality does increase, but it's something increases into the 17, 18% range. Now, if you go to the other side of that scale and you take people's blood pressure, you look at people's blood pressures in the 90s, their 1 year mortality is around 65, 70%. So it's this reverse epidemiology of the blood pressure curve.
Huh. So patients with the lowest blood pressures have worse survival.
We know that really low blood pressure can increase the risk of vascular thrombosis. So, a patient who has a fistula for dialysis, hypotension can lead to thrombosis. And so that's a poor outcome.
Yeah, I can see someone who is well meaning, trying to get the numbers to look good and may want to drive that blood pressure as low as possible. But if I'm understanding this correctly, we might be okay with a little bit of a higher blood pressure in patients on dialysis.
For those people who are off their dialysis cycles or who are a day or two behind and they're maybe above their dry weight, I would be very careful. Those are the group I would say bring them down to the 150s. That's kind of a number I think 160s is definitely getting too high. 170s, 180s, way too high. So I think 150s is the number I would try and keep people below. And, if they're well dialyzed and they've been in a hospital for weeks, yeah, that becomes a little bit more complicated. But generally, the data suggests that the best blood pressure for a dialysis patient is in the 140 to 150 range, not lower and probably not higher, but it's not clear. Most of the data doesn't really support overly aggressive blood pressure control.
All right. And then there's another nuance to throw on top of all of this, which is if we go back to the idea of autopsies in patients who are on dialysis, what we often find is these like quote unquote lead pipe vessels, which begs the question, how accurate are these blood pressure cuffs in capturing these patients' blood pressures?
So, One of our reviewers, Dr. Jeff William, pointed out that the blood pressure measured with a cuff relies on the distensibility of the blood vessels. So, in these ESKD patients that have thickened, inflexible arteries, they're at baseline going to have higher systolic readings, making it impossible for us to truly know the pressure inside of those arteries. So, even the way we're measuring blood pressure in this population is flawed.
Yeah, definitely. And then think about those low diastolic blood pressures we might see from those stiff arteries that can't recoil, right? So we probably shouldn't overtreat that increased pulse pressure that we might see. And then also to say it out loud, I did push our nephrologist to be like, hey, is there a specific diastolic blood pressure we should aim for? And sadly, similar to kind of what we learned earlier, there doesn't exist a very clear guideline or consensus on end stage kidney disease patients on dialysis, at least not yet in terms of diastolic blood pressure.
Amazing. So, let me try to recap. It's the intradialytic blood pressure, the blood pressures in between dialysis sessions that we should be focusing on when we
Yeah.
consider bigger picture blood pressure control.
Great. And then the blood pressure targets in end-stage kidney disease patients is nuance, right? It's an area that we wish we had more consensus or trial data on. You might see some nephrologists extrapolate from general population data and aim for less than 130 over 80. But we do have some data, albeit it's mostly observational data, that maybe a little bit higher systolic blood pressures of 140s or 150s might be the sweet spot. But all this is to say, this does not mean we're letting somebody sit at 160 or 170. I don't know about you, Nathan, but it hurts me every time I hear someone like, "Oh, they just live at this number." And I'm
Yeah.
like, okay." All right. Now that we went over the targets that we're shooting for, or at least what we know about the targets that we could be shooting for, let's bring another nuance into the fold. Say our patient's already on blood pressure meds. When do we give it, and how does that relate to the timing of their dialysis session?
While general medicine encourages us to really be aggressive with blood pressure control, in the dialysis patient, I would kind of walk back from that a little bit because I'd rather see higher blood pressures and be able to dialyze them than not to be able to dialyze them at all.
So, that's a great insight and a throwback to our primary goal here. The goal is fluid removal. And if we are compromising that with too aggressive blood pressure control, we're losing sight of the bigger picture.
Yes, definitely a fair point to think about if dialysis is happening or not. I think the other thing is that I think we often get paged, can we give this medication before dialysis? And I don't know about you, but I definitely didn't have a solid framework before this. And I think unfortunately it just made some gestalt decisions. Yeah, we can give this blood pressure med before dialysis or not.
First step is don't give blood pressure medications prior to dialysis. Okay. Second step is to scale back blood pressure medications. And frankly, you can scale back anything and everything. In my mind, there's no blood pressure medication that is indicated for any reason if it is interfering with fluid removal. So, if they've had a heart attack and they're still on a beta blocker, I don't think that that's warranted if it's interfering with fluid removal, because I can tell you that pulmonary edema is a greater risk factor for recurrent ischemic heart disease than a beta blocker discontinuation. So we need to be able to do dialysis. Be super careful with stopping for people with paroxysmal AFib, though. We do not like AFib in dialysis because then their heart rates go fast and we can't dialyze them. Can't get fluid off. So just be careful. Don't stop meds for AFib, but almost anything else, in my mind, all these blood pressure meds can be scaled back to allow us to do fluid removal.
I am so glad he said that out loud. And I guess the takeaway is if our patient's blood pressure is in a relatively good range, we do not have to give blood pressure meds before dialysis, with the exception, of course, if the patient's an AFib and needs a beta blocker or calcium channel blocker for rate control. Yes, then give that one.
Another thing to think about in the inpatient setting is, are these medications dialyzed and do I want them dialyzed or not? And that can help you understand, should you give them before dialysis or just wait until they're done with their session? Also, the timing of dialysis. Is the patient scheduled to get dialysis first thing in the morning, or are they going to get their dialysis at 2 or 3 p.m.? You probably don't want to hold a medication if they're not going to get their dialysis till late afternoon. Whereas if someone's getting their dialysis first thing in the morning at 7, maybe even before their blood pressure medications are scheduled to be given, they are going to be held and you can just give them after dialysis. So the timing of dialysis also matters if you're going to be holding or giving a medication based on its dialyzability and based on the person's blood pressure.
So, dialyzability just means whether a drug gets removed during a hemodialysis session. The practical implication is simple. If you're giving a dialyzable medication before dialysis, a certain percentage of it gets washed out during the session. Non dialyzable drugs stay on board regardless of when the session happens. Vancomycin's a great example. I think most internists will be familiar with how vancomycin gets dosed right after dialysis, and that's because vancomycin is highly dialyzable.
I love this point about, meds being dialyzable or not. And I think since this episode, I've definitely been a lot more thoughtful about, oh, is this medication dialyzable or not? And I think ran in even into a situation the other day where there was a patient who there was concern if they were pain seeking or not. And I realized, like, wait a minute, the pain medication they're on is mostly being dialyzed out. And so I was more thoughtful about giving a higher dose since 50% or so was getting dialyzed out.
Yeah, it definitely is, a good thing to be thinking about in the back of your mind.
Yes.
So, say your patient did take their blood pressure medication that morning and it's a dialyzable medication. And those specific dialyzable medications we'll go over next. Technically, the recommendation is to supplement 25 to 50% of the initial dose after the dialysis session to account for what was removed. In practice, though, this is rarely done. But it's worth knowing, especially if a patient seems under-medicated the day after a session and you're wondering why.
Ah, man, that is really useful to keep in the back of our mind. But we'll get into each drug class and if it's dialyzable or not in a second. But first, let's summarize and maybe apply it to a case. Say you have a patient, it's 7 in the morning, their blood pressure is 160. Walk me through your thinking, Nathan. There's no right or wrong answers here.
Okay, step one is I'm asking myself, is dialysis happening soon, like in the next couple of hours? If yes, then I'd probably hold the blood pressure medication and let dialysis do the work so we can really focus on volume removal with dialysis.
Okay, fair, fair. But what if they're like persistently above 160, 170, and dialysis is maybe more than a few hours away?
In that case, I'd say it's reasonable to give antihypertensives. Probably would start with their home blood pressure medication. But think about whether the med is dialyzable and what time dialysis is actually scheduled for.
Yeah, totally fair. Okay, so if your patient is well dialyzed, say they're at their dry weight, they're doing their best that they can with salt reduction, but their blood pressure is still high. I think the question that I often ask myself is, are we reaching for the same first line blood pressure meds that we usually do for a regular hypertensive patient? Or are there different first line medications in patients who are on dialysis?
Dialysis patients are excluded from a lot of clinical trials. And so you should not just extrapolate data from a non dialysis population to the dialysis population and assume that you're going to have the same outcomes. For example, we know that ACE inhibitors and ARBs have cardiovascular benefit for many patients, but there have been some studies done, for example, with fosinipril, an ACE inhibitor, and others with ARBs in dialysis patients that have actually not demonstrated that cardiovascular and mortality benefit. So that's in contrast to the general population.
That again reminds me of that first episode. It's like so memorable the way Dr. Janziger talked about the autopsy of these patients and how they had these lead pipe vessels, and just appreciating that their physiology is different helps us think about, all right, which blood pressure meds have seen good outcome evidence for, and which blood pressure meds have we not seen as good outcome evidence for.
Let's start with beta blockers, which are first line in hemodialysis patients. And there was this study that compared atenolol to ACE inhibitor and showed that beta blockers had much better outcomes. We'll link more in the show notes, and I'll comment that these trials use surrogate outcomes like left ventricular mass, but the takeaway is beta blockers do have outcome data behind them in the HD population.
Great. And then there's the dialyzability angle too, right? And interestingly, not all beta blockers behave the same during a dialysis session.
Metoprolol is dialyzable. And if they need to be on their metoprolol because it's improving their blood pressure or for cardiovascular benefit, if you give it before dialysis, you're just going to dialyze it out, and then they don't have that metoprolol in their body. So that's another reason to hold that medication and give it after dialysis. Carvedilol, on the other hand, is non-dialyzable, so that's a medication that you can give before dialysis unless their blood pressures tend to run on the low end.
And the big reason to think about dialyzability here with beta blockers is, of course, with AFib and people who need rate control.
AFib can be challenging in dialysis, but if they need their beta blocker, it's probably not a great idea to give them one right before dialysis. That's just going to get dialyzed out. And then, like long acting metoprolol, and then it's gone for the day and they don't have it. So perhaps giving it after dialysis is the better thing for them.
Alternatively, a good pro tip is to switch to carvedilol or labetalol for rate control. Those ones are non-dialyzable, unlike metoprolol, which is dialyzable. And if a patient goes into rapid ventricular response during the session itself, it's often triggered by aggressive fluid removal.
Yeah, and in that situation, nephrology can kind of give a small fluid bolus to slow things down. And if rate control isn't holding, then we can think about other things like rhythm control.
Next at bat, second line, calcium channel blockers. All of these are non-dialyzable, so no timing concerns.
Yes, a win.
Yes! And amlodipine in particular has randomized controlled trial data showing a meaningful reduction in cardiovascular events versus placebo in hemodialysis patients.
Nice, nice. So we can link that in the show notes for more details. But I guess the headline here is calcium channel blockers have demonstrated benefit in the end stage kidney disease population. Great. Let's move on to RAS inhibitors. So, ACE inhibitors, ARBs, I think this can often be a first instinct in just patients with hypertension without dialysis. But I think Dr. Drury flagged earlier on that might not be the case in our dialysis patients. So, what does the data say?
So, multiple trials, Fasedial with fosinapril, Octopus with olmesartan, Sarif with irbesartan, all tested different RAS inhibiting agents in dialysis patients, and none of them demonstrated the cardiovascular benefit we'd expect from the general population data. So, in practice, yes, you can use RAS inhibitors if the comorbidity picture, like heart failure, proteinuria, and residual kidney function, supports it. But don't count on them carrying the same cardiovascular punch as with someone with just hypertension.
Generally, we'll use ACEs because now they don't have any renal function. We don't worry about hyperkalemia as much. So ACEs, ARBs are fine. Almost any medicine is fine. You don't have to worry about electrolyte instability anymore because dialysis is handling it.
Okay. So ACEs, ARBs, we don't have to worry about the potassium as much. If someone is, going their typical dialysis session, it'll get taken care of with, of course, the caveat that these meds still will increase the potassium in between those sessions. And then we should talk about the dialyzability of these RAS inhibitors. Let's start with ACE inhibitors. Unfortunately, most ACE inhibitors are dialyzable, except for fosinapril.
But thankfully, ARBs are non dialyzable across the board, so no timing concerns at all.
Ah, such a win for the ARBs there. So, yeah, why don't we just put all these patients on ARBs instead of ACE inhibitors?
Yeah, so I'd say the bottom line is that if your patient needs a RAS inhibitor, just use ARBs. Use an ACE inhibitor only if cost is a genuine barrier. And if you do use an ACE inhibitor, fosinapril is the only ACE that won't get washed out during dialysis.
I think that there's a lot about cardiac remodeling. And so whether we should be more aggressive with MRAs and selective MRAs, I think is probably reasonable in trying to improve cardiac remodeling. But I think it's that, I mean, as you say, it's definitely a fine balance between overtreating and undertreating.
And that MRA comment is interesting. Medications like spironolactone, eplerenone, and the newer finerenone. We'll use those in heart failure for cardiac remodeling, but we have inconsistent results about their benefit in dialysis patients. I'll just say that they are ongoing randomized trials on MRAs, and the evidence is evolving.
The one medicine I would say just be a little bit careful about is clonidine, because clonidine side it's anticholinergic and makes people thirsty and it makes them drink. And so I use it sometimes, but be careful because it can sometimes lead people to gain more and more weight. And so it's not a perfect drug in dialysis, but I still use it and I use the patch a lot because we have a lot of non-compliance, and this way we can see if they're actually taking it.
So, clonidine's anticholinergic effect drives thirst, which drives fluid intake, which drives volume overload. That's the exact cycle we're trying to break. It's not contraindicated, but be thoughtful. And the patch idea, when adherence might be an issue, I must say, is quite clever.
Definitely, definitely. All right, so let's bring it home. Say we have that same patient who's hypertensive. We've done our best to optimize their dry weight. They're doing their best with their salt intake. What is the order of operations in terms of medications?
So, beta blockers first. These have strong outcome data. Prioritize non-dialyzable agents like carvedilol or labetalol to avoid timing headaches and maintain consistent coverage. If you use metoprolol or atenolol, which are dialyzable, give them after dialysis. Or if they're on metoprolol for AFib, consider giving it prior to dialysis and or increasing their dose by 25 to 50% to account for how much is dialyzed out.
Yeah, great. And then second up, we have the calcium channel blockers. Amlodipine has the best evidence, and then calcium channel blockers, thankfully, are non-dialyzable, so we have no timing concerns there.
Third, RAS inhibitors are reasonable, especially if there's a comorbidity driving the choice. But don't rely on them for cardiovascular benefit the way you would in a non-dialysis patient with hypertension. Overall, we should have a preference for ARBs, but if you use an ACE inhibitor, fosinapril is the one that won't get washed out.
Right. And then I think threading through all of this, right, we're asking ourselves, is the medication dialyzable or not? That changes maybe when you might give it, and if we might see the full effect of that medication by the end of the session, and then whether we want to give a supplemental dose afterwards.
So we'll have a cheat sheet for the antihypertensives that get dialyzed out and the ones that don't in the infographics. But for me, I think it's easiest to remember that metoprolol, probably the most common beta blocker we see, along with atenolol, and then most ACE inhibitors that are getting dialyzed out, and then basically everything else does not.
Okay, I like that. That simplifies it. It's basically metoprolol and then most ACE inhibitors, as well as atenolol, that's going to get dialyzed out. I like that. Thanks, Nathan. That's very helpful. And that is a wrap for today's episode. If you found this episode helpful, our ask is to please share it with your team, your colleague, a future budding nephrologist like Nathan. I think these patients are everywhere. I think having some type of framework to just think about it a little deeper will make such a big difference.
Thank you to Dr. John Danziger and Dr. Erica Drury for their time and expertise. Thank you to our reviewers. And as always, opinions expressed are our own and do not represent the opinions of any affiliated institutions. Take care.
I'm glad we made that change. I was like, this stuff wakes me up at nighttime. Like, I hope somebody doesn't take this as the gospel.
Yeah.
Sweeper.
When I found out I was going to be a parent, I immediately felt a lot of anxiety and worry. So I went on to BetterHelp to try to look for a therapist to help me with that.
My relationship with my family and with my boyfriend and with myself were suffering. I really needed help.
I was ruminating a lot. Really getting those thoughts out to a therapist and getting feedback was just life-changing.
Discover what BetterHelp Online Therapy can do for you. Visit BetterHelp.com today.